Good evening, ladies and gentlemen, colleagues and friends. Welcome again to another SPG webinar on the topic of improving post and course. Joining me live tonight, once again, my partners in crime, we have Dr. Agnes.
Hello.
Dr. Zoe Potres.
Hello.
And Dr. Johnson Chou.
Hi.
As always, tonight's webinar is live and interactive, which means that if you have any questions, anything that you want the panel to discuss, I will try my very best to pass on your questions to the panel. You can key in your question as you scroll down below to the end of the page. And for the ones that wishing to receive your CPT certificate, please also remind to enter your details as well. I also want to make a mention to all the referring dentists. Thank you so much for your support in us over the years and over during these recent periods of time. Without your support, we would simply cease to exist. So thank you so very much. Tonight's webinar, of course, is on the topic of improving post and course. So just a couple of housekeeping messages. Firstly, none of the presenters here have received any financial gain from any of our sponsors, and all the content of this webinar are of our opinion. So please do exercise your discretion in interpreting these results. This webinar would not be possible without our sponsors. One, to Noble Biocare. They're the ones that have been sponsoring me from the very, very beginning when I first graduated as a specialist. In terms of the mentorship program, which I want to make a mention of, is that anyone who's interested in starting up in your implant journey, this is a terrific program which I am the chair of. It's split up over 4 different modules covering treatment planning, surgery, restorative, and also full arch as well. So something for people of all different degrees in your implant journey. So you can simply just Google that title, and they'll bring you to the right link. Credible, we all know Sandy and Teresa, who's been serving our community for a long time. They're, of course, the right people to go to with any type of loans that you may be interested in. Cable Kerr, housing a terrific range of restorative products. And this evening, in terms of post and cores, they do offer, in terms of fibre post, and a number of composite resins, including a bulk fill or a particular reinforced composites that's terrific for the core material, which will be touching on throughout the evening. Last but not the very least, Experian Insurance Services. Mr. Mark Sachs is the person certainly to contact if you want to have your insurance products serviced or reviewed by Mark, who is most experienced in doing so. They do offer some promotions. One is a cashback on any new customers, so do talk to them about that if you're interested in signing up with them. And 2, in terms of the QR code, you can either scan that in now, or you would have received a QR code in your email invitation. So feel free to join into the draw for a $150 gift voucher. And a little bit about ourselves, Sydney Prosthodontic Group. We're located in Chatswood, offering a full range of restorative services and surgical services. Between me and the team, we're capable to handle most that comes our way, whether it being a restorative-driven situation of warm dentition, heavily broken down dentition, to surgically in terms of extraction or implant replacement of certain teeth. At SPG, our goal is relationship building, not just to provide an exceptional service to you, to your patients, but also in terms of continued education or any advice that you may seek moving forward. So feel free to contact us if you do have any questions, whether it's regarding your patients or for yourself. Between me and the rest of the group, I'm sure we have enough resource or brain power to be able to help you out in whatever capacity that you see fit. And that's get on to the topic at hand on improving post and course. We all know that after endodontic therapy, reaching a good coronal seal is always extremely important to safeguard the outcome of that tooth in the long term. Now, the restoration that goes on top of the tooth sometimes could be accompanied by a dental post. Since the development of adhesive restorations, there has been a slight paradigm shift, perhaps reducing the need of post or using flexible posts. Now, there are some cases that's very obvious, perhaps a post is indicated, while other cases not so obvious. So tonight's presentation really aims to examine the literature, look at when a post is indicated, when a post perhaps is not indicated, and if it is indicated, well, what type of the post we perhaps should place. But before we jump right into the idea of post, first I think we should cover a little bit on when we don't need a post, because not all endodontically treated teeth would always need a post. So, or we could say that not all endodontic treated teeth would necessarily need a crown. For example, some teeth may not need much restoration at all, or maybe others, perhaps some sort of an onlay may be sufficient. And in those cases, perhaps a post or a crown is indicated. So what I'm trying to say here is that although the topic is about post and core, but that by no means indicate that every endodontic treated teeth must receive a post and core. So that's the first message we want to carry out this evening, is to make it loud and clear that when perhaps a post is not needed. So what I want to do is, if I can get Dr. Agnes Lai to kick us off the evening to talk about the indications of when perhaps a post is not required.
Okay, certainly, Ben. Okay, so basically when we think about post and core, the reason why we often say these two things together is that the fact is we should only consider the use of a post to help retain our core restoration. So when there is no auxiliary retention needed to hold on to our primary restoration, or whether it then becomes a core for the definitive restoration, then we really don't need to consider the use of a post. So in summary, while today's webinar is not completely on your definitive restorative choice, having that in mind will help us determine, well, do we need to have a post at all to help retain our core? So let's have a look at this particular scenario here, where we have a endodontically treated molar with a mesial-occlusal amalgam restoration. So in this particular slide here, you can see that the amalgam restoration is being removed. And as we take a look into the orifice and the chamber, we can see that it's now obturated. And what we can also see is that it has multiple canals, and these canals are of different directions and angulations. So in situations like this, where we are able to heat out the cervical aspect of the gutta perca to at least maybe 3 to 4 millimeters, then as we engage the restorative material in these different directions, it becomes very good auxiliary retention for the intracoronal restoration that we provide. So in the third row, you can see that the restoration is being placed, and we can complete this whether it is for an onlay or a crown. But we are quite certain that with those particular anchorages into different angulation of the orifices. The intracoronal restoration is got good retention form, and hence we will not need to have additional post per se to help with our restoration. So as I aforementioned, let's go through a case. Not every single tooth we would require a post. But when we come to consideration of endodontically treated teeth, we do want to provide primarily a very good coronal seal and a predictable coronal restorative outcome. So for me, primarily full coverage restoration often is considered. So when we typically receive back a tooth that has been through endodontically treatment, and in this case scenario is being supported by a band, we will need to consider removing all the restorations to take a look at how much tooth structure there is left. In this situation, you can see that both the proximal aspects are quite deep and there isn't much enamel in those areas. While we assess the buccal and the palatal remaining tooth structure, we also consider, well, if we were to provide a very good marginal seal for this restoration, I would personally consider having a full crown restoration. Therefore, my intracoronal restorative form here, I have to consider not the existing cavity wall per se, in these areas. Is it showing? Yeah. Okay. So what we will have to do in later on, we will have several other cases to show you as you draw an imaginative crown preparation. And therefore, we would need some auxiliary retention to hold on to the core. And in this instance, by heating out each of the gutta perca, it will allow us to have different direction of what we so-called amalgam pins, or just these intracoronal slots. So when we then provide the restoration, I often will use quite a different color material so that we could easily identify as we remove the band and go into the preparation, especially in the depth of the deeper margins that you have to locate. You can see where you've got a good seal and go past and having a good ferrule effect onto your final restoration. And this particular core, having engaged into the different orifices in the different directions, we know that we can be quite certain it's got good enough retention form and therefore would not require additional post. Here we can see that, while in some aspects we've got a very tall clinical crown height, really in the proximal aspect, the finishing line is just a little bit beyond the existing core margin. But once we are able to complete a core preparation nicely, we are also able to extend a very fine gold bevel margin in this type of restoration to ensure that that slip fit onto the dentine, embracing all the way around the tooth circumferentially, not only provide a full coronal seal, full cuspal coverage, but also a very nice marginal seal that can protect the long-term outcome of the remaining tooth as well as the endodontic treatment outcome. So at this point, after having shared a case that doesn't require post, I'm going to pass it back to Dr. Ben Lee to go through with us some other principle, in particular discussing about Ferrule.
Thank you so much, Agnes, and thank you for the reminder for us once again that tonight's topic, it's not about deciding on restorative design, right? When the tooth is indicated for onlay, when the case is indicated for crown, etc. It is slightly a different topic for another night. So tonight's topic is primarily about post and cores, and we've covered it for the ones that's just joined us. Again, I just want to state that not every endodontic treated teeth will need a post, although the topic here is about post and core. So we've covered which perhaps clinical situation does not need a post. So hopefully for the rest of the presentation, people are not going to get too confused about why aren't you guys discussing about teeth that does not need a post and core. And also thank you for the questions that's coming in. So thank you for that. Keep the questions coming. I will be passing on these questions to the panel at the appropriate times when we are discussing on those individual aspects. So please do keep them coming. And another slight subtopic that I want to quickly touch upon before we jump into post and cores is the concept of Ferrule effect. Because a lot of the cases that we'll be discussing throughout the evening, we may be mentioning on the concept of adequate or inadequate or insufficient Ferrule, and that can be subjective. So I want to make certain objective descriptions on what perhaps is considered adequate Ferrule, so that when we do talk about this concept later on in the evening, that we're all on the same page. Ferrule, I'm sure we all know what that is, which is that collar of natural tooth structure or dentine, which your final crown restoration is sitting surrounding. It's what's really providing the resistance to fracture of your core or of the entire restoration. There are a lot of literature available on what is considered the minimum Ferrule height, which is 1.5 millimeters, which is the bare minimum. Quite a few articles even say that 2 millimeters is the minimum. So there are some differences between different authors, the majority of which are laboratory-based in vitro studies. but we do know that you need a circumferential 360 degrees of a bare minimum of 1.5 millimeters height. So for example, the case on the right have 0 Ferrule circumferentially. Not only the height is important, but also the thickness of the Ferrule is also important. Take the case on the left, for example. You want to see at least 1 millimeter of thickness, and that is once after a crown is prepared, not beforehand. Whereas the case on the right, we could see that both the buccal and perhaps in the palatal is rather thin in terms of that Ferrule thickness. So anything that is less than 1 millimeter thick is not actually considered adequate, because it's very easy to break, of course. There are lots of finite element analysis studies that shows that when there isn't adequate Ferrule, and let's say whether you have a post or with or without a post, irrespective what type of post, right? And you try to load this this object or the tooth or the restoration, the stress is usually transmitted down throughout that post system into the root significantly. Rigid post, and we'll cover this in detail, of course, about what happens when you load a rigid post versus non-rigid post. But all the studies are showing that there's a lot less of that stress being able to be distributed around that cervical where the Ferrule would have been when you don't have enough Ferrule. So therefore, that would potentially increase the risk of some sort of fracture, whether it's a root fracture or a coronal fracture of some sort. So that's why, of course, Ferrule is important. So whenever we are moving forward, talking about adequate Ferrule, right? So we now have concluded that you need a minimum of vertical, 1.5 millimeters, and horizontally by 1 millimeter. So now let's go into the actual post and core, or particularly about a post. When is a post indicated? There are quite a few type of different classifications out there in the literature. But one sort of somewhat simplistic way of looking at it is by considering how many walls are missing. And they simply break down a tooth into having 4 walls, buccal, palatal, mesial, distal. And by counting how many walls are missing, then that's where that recommendation comes in. So for example, whenever you have either no wall missing, which is that picture on the left-hand side with those anterior dentition receiving root canal treatment, the tooth by itself is intact, so there's no wall missing, to up to 2 walls missing. So for example, the premolar or the molar situation, You can see both the buccal and palatal, or the buccal and lingual cusps are present, which means it's the mesial and the distal that's missing, which is very commonly seen in our posterior dentition after endodontic treatment. The vast majority of these cases, according to literature, may not require a post, because as how Agnes have explained earlier, that core material can be well retained by the walls, whether by bonding or sometimes via some sort of mechanical, even retention features. And in terms of what is defined as a wall, or as in how thick is a wall, once again we apply back to the Ferrule concept that we talked about earlier, that you have to have at least, after crown preparation, of 1 millimeter Ferrule thickness for that wall to be considered an adequate wall. And in other words, if you have a very thin sliver of buccal or a palatal lingual cusp, which is less than 1 millimeter, and you know that after crown preparation there's practically nothing left, well, that does not consist or be considered as an adequate wall. So take this case here, for example. There's, of course, this is we could see clearly that there's 2 walls missing. There's a buccal and the palatal that remains. However, after assumed that we're going to go through with a crown preparation, and you're going to remove, say, 1 or 1.25 of that buccal tooth structure, then the remaining part of that dentine or the enamel is very, very little. Definitely, in terms of thickness, less than 1 millimeter thick. So therefore, this case may be considered having 3 walls missing as far as this particular discussion goes. The vast majority of the literature would support that if a clinical situation has 3 walls missing, or all 4 walls missing, then certainly a post may be indicated. So take this case here, for example. This young lady has suffered a catastrophic fracture of her anterior incisor. The tooth is already endodontically treated. So, of course, we would recommend some sort of a post and core. Now, once that's done, in this particular case, I've chosen to use a fiber reinforced post and a composite core. And at this stage, we could see that although I have enough retention and resistance form for a crown, but there's no Ferrule effect. So in this particular case, we felt it was appropriate to prepare the crown subgingivally, able to reach adequate Ferrule circumferentially, i.e. this is a long bevel styled preparation. And then the final prosthesis, because we are luting subgingivally, therefore I needed to use a luting cement that's more moisture sensitive. Therefore, I decided to go with a PFM restoration and a 360 gold margin. And given that I dropped the margin subgingivally adequately, I was able to hide that metal and still achieving a reasonable aesthetic outcome, and yet still achieving more than 2 millimeters of circumferential Ferrule. So, I went through that case very quickly, but this topic isn't about crown preparation, which we have done a previous webinar on that. So if you're interested in looking at improving crown and bridge work, certainly go through our website, and there's another topic discussion available. So when we are examining the different type of posts out there, well, what's the function of a post? I think throughout the evening, both myself and the rest of the presenters will be referring to core retention, and that's the primary function of a post, is to help you to retain your core. But of course, and you can see that doesn't matter what a type of post, right? Whether it's a metal post, whether it's a fiber reinforced post, they all have some form of micromechanical or macromechanical features to help the post at locking in the core. Ultimately, of course, we want the post to be retentive too, right? We don't want the post to come out easily. So there's a number of ways that during post preparation, you might want to maximize the retention of your post. Now, certain strategies may involve increasing the post length, right? Making the post sort of as long as possible, or increasing the diameter of your post, therefore also increase the surface area. You may want to use something like a parallel sort of design, or using a threaded system, so it's almost looking like a screw. Last but not the least, some sort of a cast system, which is custom made, tailored to that specific situation. All of these potential concepts can help you to maximize the retention of your post, which will then, of course, retain your core. However, the problem comes in when you do things a little bit too much. Sometimes you may weaken the underlying tooth structure, and therefore some of these concepts may increase the risk of root fracture. So for example, take this case here, for example, of cast post and core. We could see that the clinician here have certainly made sure that the posts are quite long, they're quite wide. They've chosen to use a cast system which are highly adaptive, right, to the shape of the canal. However, unfortunately, the remaining dentine is rather thin, and unfortunately, both of the lateral incisors suffered a catastrophic vertical root fracture. So, unfortunately, we had to extract those teeth and carry out some sort of implant replacement. And take this case here, for example, where this particular clinician was certainly aiming for consistency in terms of the post length and to some degree the post width. However, yes, the posts are certainly long and perhaps wide enough, but there are some clinical instances which may be too long or too wide for certain canals, and therefore resulting in quite catastrophic outcome. So what I want to do now is just to go through post preparation principles, because there's lots of different philosophies exist in how to safely prepare a post space to reduce these risk factors. So I'll pass the baton now to my colleague Dr. Zoe Potres to come with us on post space preparation.
Sure, thank you, Ben. So with the cases that you showed in just earlier on, Ben, it's important to remember that posts, they don't reinforce the root of the teeth. They actually weaken the tooth. They remove, especially if there's excessive tooth structure or excessive dentine has been removed. So the post aim is to retain the core. So we might look into certain things that will help us decide on what sort of, when to use a post, and we covered on that earlier on. And definitely, if we have more than 50% of the tooth structure that has been removed, then a post is indicated. But if it's less than 50% of the tooth structure, then we may just consider having a crown on the tooth as opposed to a post. If the crown preparation height is about, has a sufficient height of about 3 to 4 millimeters, then that's enough to retain our crown. So we don't really need to improve on our core foundation after that. With the anterior dentition, if we look at the anterior teeth, majority of the cases, if it's just a endodontic excess cavity and the entire tooth is intact, then definitely we can just restore that with composite resin. At the end of the day, the post is only indicated to retain the core. So by removing a tooth structure to put a crown on that tooth, you're actually weakening the tooth. Anterior teeth are more subjected to non-axial forces. So it's important to retain as much tooth structure as possible. So generally it's decided as, or if you think about it, if the majority of the tooth or more than 25% of the tooth is missing, then we may consider putting a post and core and crown, but anything else, only a crown might be indicated. With the posterior dentition, the molars, they have a larger surface area. They might have some retentive element, as Agnes showed you earlier on with that molar. So there might be sort of boxes or grooves or intraradicular areas that we can incorporate into our retention. So most cases don't actually require posts. If less than 50% of the tooth is missing, then possibly only core and crown is indicated for those endodontically treated teeth. But if it is more than 50% of the tooth is missing, then we can consider the post, core, and crown. So if you think of it, which canal to choose for that post to retain our core is usually the straightest and the largest canal. So for the maxillary molars, the palatal canal is the biggest and the largest that's recommended to use, and in the lower molars it will be the distal canal. So if we are thinking of the type of post there are, so we have the rigid post and the non-rigid post. Now the differences between rigid is they don't bend or fracture easily. They compose of two different materials. So some of them is titanium alloy and others might be made out of stainless steel, or they could be casted as well. But these two types of posts here are prefabricated. So these rigid posts are indicated in teeth that have less than 2 millimeters of ferrule remaining. So Dr. Lee touched on earlier on the importance of ferrule, and the post, if it's a rigid, it's seemed to be able to distribute the forces through the canal system, minimizing the stresses on the cervical dentine. Whereas with non-rigid post, they have a modulus of elasticity that's quite similar to dentines. So the non-rigid posts, they could be the fiber reinforced. So for example, they might be quartz or carbon fiber or glass reinforced composite, like a resin post. Now they are recommended in teeth that has less than 2 millimeters of ferrule. And they do have because of the physical flex or physical properties, these posts, they do distribute the stresses in different part of the tooth. And we'll touch on that in the next slide. So if we are to look at this diagram here, you can see that the stresses are distributed primarily in two segments. One is on the cervical part of the root, and this is exactly where the crown of the tooth has, like a cervical margin of the crown of the tooth finishes on the root segment. And the other part of the stress, or the other part of the tooth root that will receive the stress, is the junction between the middle and the cervical part of the root again. So this is exactly where the cortical bone comes to an end on the root. So these are the two parts of the tooth root that will receive the majority of the stress. Now the other part will receive the stress is through the root canal system. So if you have more than 2 millimeters of ferrule, the force distribution will be mainly absorbed by the ferrule as well as the post itself, therefore minimizing that fracture or incidence of root fracture. But in cases where we don't have the ferrule, especially if we are using a non-rigid post, what the studies have found that the stress distribution is actually concentrated at that cervical part of the tooth where the crown junction with the root. And because there's no ferrule, all the stresses are going to the bond, the weaker cement layer, leading to formation of some sort of marginal gaps and eventually fracturing not just the post but also tooth fracture. Now, post can be two different shapes. So we touched on the rigid and non-rigid, but within these criteria, we have the shape of being parallel and tapered. So parallel posts, they are a lot more retentive. They're actually preferred because they have better retention, and being a parallel post with a parallel finish at the end, it seemed to have a better stress distribution than tapered posts. Tapered posts are less retentive. There's also incidence of increased risk of root fracture, especially if in cases where there's a really heavy occlusal load on the tooth. It is thought to have some sort of wedging effect at the end of the root, so it leads to that fracture. So the recommendation, although some studies do use parallel, some studies do use tapered, but the overall recommendation is to use some sort of a parallel serrated type of post, generally what's indicated. Okay. Now, the post could be, I think Dr. Lee touched on that earlier, two different sort of designs. So you have the threaded post where you sort of actively engaging the dentine of the root. The threaded post, they are thought of to cause a bit more incidence of fruit fracture, especially if they are tapered type of threaded post. So they're reported to have more than 20% or 20 times the risk of root fracture than parallel one type post. The cemented ones, on the other hand, they don't engage the root walls, the root canal walls, but they are in close proximity to the root canal walls. So they're relying on the luting cement for their retention, and they are preferred as opposed to the threaded type. So in terms of the retention, some posts will come as smooth. They tend to be less retentive, and others will have some sort of serration or some sort of crosses alongside the surface of the post, and that will help it become like a retain to the cement, and they're a bit more retentive in that way.
So if I may interject, there's a question that I think, sorry, excuse me, that might be quite interesting for a discussion. One viewer has asked that he or she has a particular technique which is into the post space. I'm assuming, or if my understanding is correct, is that there is no post, but instead they're using a flowable or some sort of a composite only into the post space. Then subsequently, I assume the rest of the core, of course, is also in composite, and finally finishing on some sort of definitive restoration. They did not specify whether this is for a crown or whether this is for an onlay. So in other words, I'm guessing it's a homogenized composite resin that's extending from the dowel, the post, into the rest of the core. And the question is, what is your view on this method? So it's another novel design.
Okay.
Since we're
Right.
talking about
Yes.
the different types of
Yes.
posts in conceptually speaking, what would be your view on that?
All right. So just I'm assuming will be like a dual cure.
I assume
resin,
so.
Because
Yes.
a light cure will be quite impossible to cure. I actually don't know if that's. I haven't used that technique before, but I've had read on other clinicians who do reline their fiber, so the circular fiber reinforced resin post, and they do reline it with some sort of a composite material that's a dual cure to engage the shape of the canal a bit more closely or appropriately.
So they're customizing a direct post.
A direct post to. So this is what I've come across in the past, or with the Endo-crowns where they put that into the maybe 2 millimeters of the canal space, but not so much the whole post space. So I don't know in terms of the strength of that post, but probably if you think about it, if it has the similar module of elasticity to the dentine,
Yes.
then maybe it's what might provide sufficient retention. But personally, I haven't used that technique in the past.
I think later on throughout the evening, we will be talking about fiber reinforced post. I think that's the Dr. Agnes Weiss section. And I think throughout that section, we'll be talking a lot about the effect of ferrule, whether there is a ferrule, whether there is insufficient ferrule, and what happens to that post complex. So this may fall under that umbrella. So my only concern here is that if you have adequate ferrule in this scenario, I think then that may work quite well, as in that composite post is helping to retain the core, right? But if there isn't adequate ferrule, and now you're really putting a lot of stress into that region, then that may have certain fracture type of outcomes. So, but that's a really good question. So thank you again for all the viewers for sending your question. I'll be again directing these questions to the panel. All right.
Okay.
Thank you, Zoe.
Yep.
Keep on going if you don't mind.
Thank you. Now, the other thing is, please remember, there's different systems. So, for example, this system on the left is a metal system. It's a parapose system. These will have their own drills, their own color coding, which might be quite different from a fiber reinforced one, as you can see on the right-hand side. So, always use the specified drills that comes with the post kit itself, and use the color code post to the color coded drill that we finish with. Now, tooth anatomy, not every tooth is able to have a post. Sometimes we have to really understand radiographically the anatomy of that tooth, the canal shape, whether there's any issues with that canal in terms of invaginations, or might be a ribbon-shaped canal, or that might increase our risk of perforating the sort of the root, or even root fracture, initiating root fracture. So radiographic evaluation is important and paramount in terms of when it comes to putting a post and core. So here we can see the different canal shapes. So not all canals are circular. You might have different shapes. Some are ovoid, some are like a ribbon form, H-shape, a C-shaped canal. It could be calcified. So a prior assessment is important. Now, the shape of the canal will also help us decide what kind of post we might use. For instance, if you have a small circular canal, then perhaps a parallel sided post that is also circular will be the most appropriate. It's a prefabricated. It will fit that canal in close proximity to the canal walls. But if the canal is quite flared out or tapered, it might have a large oval opening, then perhaps in that case, if you use a prefabricated one, it may engage only the last 1 or 2 millimeters, and the rest of it will be sitting and relying on the resin cement, which will break and degrade with time. So it might not be as retentive. In that case, the indication is to use a custom cast post and core will be more appropriate. Now, the other thing we look into is the length of the root. So even though we say that the post needs to be the longer, the better, because they're going to be more retentive, but also they also help with stress distribution. They'll have better stress distribution the longer the post is. But we have to be mindful if the root might be short or curved, the canal. So again, radiographically, we have to really assess. So your post and core should be have the features of to preserve and take the biology of the existing tooth into consideration. In multi-rooted teeth, we could use multiple posts to help with the retention if the tooth is badly broken down as well. So the length of the post, as a general guideline, the length of the post shouldn't be shorter than the crown length. Studies have found that if the length of the post is shorter than the crown length, there's a higher incidence of a fracture than grooves that will have equal length. So the recommendation throughout the literature is to choose a post that will be at least equal to the length of the crown, or equal to half the length of the root, or at least two-thirds, maintaining your 4 to 5 millimeters of apical seal, for sure. Now, the width of the post is another very important criteria, things to consider. So the criteria for width selection is we have to be as conservative as possible, removing as minimal to structure as possible. We have to be preserving the dentine. So the post will need to be surrounded by at least 1 millimeter of sand dentine, and it has to be if you think of the narrowest part of the root, which is where the post is finishing, that part needs to be less than a third of the width of the. So the post needs to be less than a third of the width of that remaining dentine. So if you think about a lower incisor, for instance, it has a small diameter, a small narrow roots, Usually a 0.6 millimeter is sufficient, whereas a maxillary incisor or a canine might have a 1 millimeter, again, depending on the width of that root. But as a general guide, 0.8 to 1 millimeter is quite commonly used in quite a few clinical situations. So the image that you see on the left-hand side, that post is quite large, so it's undermining the tooth structure. So we need to fit the post into the canal, not fit the canal onto the post. So just again, the sizes, as you can, depending on which system you use, just know your system. For example, this is a parapost drills. They have different color coding. Each color code will have a different diameter. So pick the system, understand which one you're using, and also understand that not all posts will have the same radio opacity. It doesn't matter as long as you know how the clinical presentation or the radiographic presentation of that. So on these posts, there's a lot of differences in the radio opacity from different manufacturers.
And some of the posts are actually quite radiolucent that I found,
that
especially in some of the earlier
yep.
generation ones. Once you put it in, you take a radiograph, you
where is it?
Yeah, exactly. or it's as a new patient that
yeah.
you have,
yeah.
and you've done some sort of bite one or PA, and you go, oh, good God, there's no post in there. But actually there is.
There is
so that's something to watch out for.
Yes.
Now, Zoe, if I can ask another question, because previously on one of the slides, again, this is a philosophical question, that for multi-rooted teeth, you previously made a mention that sometimes you can consider placing multiple posts. So here's the question. Is 2 small posts better than 1 large post?
2 small posts.
It's very philosophical.
Yes. Well, depend again on how much tooth structure is missing. So quite often we might be able to customize like a smaller, shorter post that will give you a better core structure. We've made quite a few cast posts on core where things are locked into each other, and they like a jigsaw puzzle and fit together.
A then B then C,
yes.
Right?
And sometimes you can't really engage quite deeply into the canal, depending if there's a curvature or things like that. So maybe there's no right and wrong. You could do 2 shorter posts in a molar, but
yes,
yeah,
we assume it's
in the 2 shorter post situation, it also, like, your post selection and the preparation principle does not change too much. The only advantage when considering multiple posts as opposed to the one is that there is that flexibility on perhaps choosing a shorter post, balance with the divergence between the posts. So, for example, if you have 2 shorter posts, but they are more or less in the same path of draw, there is really no real advantage or ability to shorten those posts to resist that retention of the core, which again fall back to the primary reason as to why you want to have the post. And arguably, in some of the scenarios where we can quite patently put in our restorative material engaging 3 to 4 millimeter in depth, like similar to some of the suggestion of another audience before asking to just put in the restorative material. I will later recap on that concept. But that's quite similar to just injecting the material into those shorter post space per se. So I think the important thing here is still the goal is to minimize unnecessary reduction of tooth structure, especially around the intracanal area, as well as to consider the angulation, that divergence of what these posts, multiple posts may offer. Yeah.
A lot of your, I guess, heavily broken down teeth, like for example, it could be, say, an upper premolar, right? Got 2 roots, 2 canals, and a lot of the premolars, like one of the pictures that you've shown, that the roots are very skinny. So you probably can only get away with using a fairly thin post.
Yes.
And if that tooth was quite heavily broken down, I think it's perfectly fine to consider 2 thin post, which will
Absolutely.
help you to retain your core and help you to distribute that force. That way you're not undermining the structural integrity of the root or the tooth.
Yes.
So I think it really depends on the clinical situation to justify that. But certainly I think that there are some cases that perhaps two smaller posts might be bigger than one humongous post. So.
Okay, so if we come into preparation, now I'll just run through just the general guidelines, and then we'll go through in a bit more details on how to prepare a post. Of course, you've got to do it under rubber dam. So this is the gold standard. Remember that to minimize or remove minimal tooth structure, take multiple radiographs along the way, and do enlarge the canal gradually. Now, sometimes we can also might look into preparing the crown. So it's really hard to visualize how much remaining tooth structure there is without doing a crown preparation on the tooth. And that will, similar to the case that Ben had shown earlier on, where after preparing and building up the core, he found that he needed to go subgingival. So this is perhaps something that we can decide on where your crown margin earlier on as well, prior to putting that post in place. So gate Glidden drills, these drills are the starter drills, let's call them. They, as you know, they are all safe-sided instruments. They're not an end-cutting instrument. They come from different sizes, from 1 to 6. 1 is being quite brittle, rarely use that size. And 5 and 6, they're quite large, and they can remove quite a lot of tooth structure, so they probably not recommended as well. The most commonly used sizes 2, 3, and 4. Now the gate Glidden, you've got the rubber stopper that will help us dictate or determine the length. Use them with a low speed, probably 700 to 1000 RPM is the recommended speed. The faster you go, it's just going to find that it sort of start vibrating because of the long shank. By applying like a brushing vertical pressure on the gutta perca, it warms up the gutta perca and eventually removes it out of the canal. So here, determine your working length from either knowing the endodontic treatment working length or radiographically, if you haven't done the root canal yourself, radiographically on the X-ray, determine a working length and work towards that working length, and again assess throughout the procedure that you are at the accurate working length, leaving that 4 to 5 millimeters of intact GP toward the end of the root. So once you remove the gutta perca with the gate Glidden drills, make sure that there's no remaining GP on the wall of the canal where you prepared, and that will help us later on in the cementation process, and also in visibility, so the canal becomes a bit more easier to work with. Moving on from the gate Glidden, so we've used 2, 3, or 4 sizes of the gate Glidden, depending on how wide is the canal. Then we move into the parapost drills, and again they come in different color coding. So they from the brown being the smallest to the black being the largest. The last 2 colors, purple and black or gray, they're really too big. Rarely use those. So always start with the narrowest and then work yourself sequentially and gradually enlarge the canal to avoid overheating throughout the process. And these drills are quite risky, so there's a chance of diverting from the axis of the canal, and if you put too much pressure on one side, it might lead to perforation and risking damaging that tooth. So it's important, if you think there's a lot of resistance, maybe take a step back, remove it, use it by twisting it by hand, just to re-gauge where you're at. Come back to the gate Glidden burrs as well, to ensure that you're actually on the same path of the canal preparation, and then come back and use that. Now, You don't have to enlarge them to all the sizes. Of course, judging by the minimum size that will that will achieve the preparation and still has a kind of a snug fit within the canal is the size that's recommended. Not increasing it past that third of the width of the root at the narrowest part of the tooth. Now, this case here is a good example to show the parapost drills, and that's a teeth that has been endodontically treated, and they were referred to us after they put these all ceramic crowns on the 4 incisors. The patient has developed a fistula, and radiographically, the post looked okay on tooth number 22, but the thinking process was there might be a root fracture because the GP that gone through the fistulas was pointing right at the end of the post on the tooth 22, and it wasn't apparent that until the day of the extraction that the dentist had inadvertently perforated the side of the root using this throughout the process of the preparation. So the parapost drills are quite risky in that regard. So just make sure you always check and recheck that you are in the same path or on the correct path of the canal preparation. Now, once the canal is prepared, now we have to try in the post again to the corrected estimated working length that we're working toward. So you can we can put a like a rubber stopper on the end of the post, insert it to achieve that length. Make sure that it's seating down fully. Once confirming that the post is seating down, we can remove or trim the excess part, so it's not too long past what we need in terms of the core retention, and then we can go to the cementation process. Now, with the cementation, again, we have to remember if we're cementing onto something that's not a clean field, then the cement is not going to hold. So the canal space needs to be really cleaned out properly. So you have to wash it away from saliva, bacteria, whatever contaminant that might be in the canal. Any remnant GP needs to be removed from inside the canal. So we use a triplex and dry it out with a paper point to ensure that it's fully dry. Follow the manufacturer recommendation for the cement that you use. Personally, I prefer to use a resin type of cement, and we can apply that into 2 parts. So the first part, when you apply the resin cement, is actually inside the canal space, and then make sure you coat the post as well fully with the cement, and then seat it using tweezers into the canal with some pumping pressure to vent out any excess cement that will come out coronally. Ensure that the post is seating down to the working length that we have decided on, and then firmly hold it in place. Put a flat plastic or using the tweezers again. Remove any excess cement and light cure it in place. So this is the cementation process we covered, but retrievability is another factor in terms of post selection. Some posts, for example, zirconia posts, they virtually impossible. We can't take them out. Resin fiber posts, they are a bit more forgiving. They're easy to remove because the endodontist can cut through them and remove them. And there are certain tools. Sometimes you can use an ultrasonic scaler to vibrate that post out, or there are some tools as well. For example, post removal tools. I think they called like a giant post puller or something like that. They work as a trephine pretty much. So they create some threads onto the coronal part of the post, and then using that tool to grab onto it and vertically displace it out of the canal, enabling the retreatment if that ever is the case. So I'll pass you back to Ben.
Thank you so much, Zoe. Great coverage, as always, on post-space preparation and all the steps necessary. So once again, ladies and gentlemen, thank you so much for sending in your questions. You can email us your questions or your cases through our email, which is at Brett has got that email address up, or alternatively, you can just email to info@cpg.com.au. I have been sneakily going through the emails on my phone and answering those questions as I'm going along, so feel free to do that. That's not a problem. There was another question earlier about what was the cement that I used to cement crowns, PFM crowns, or full gold crowns for that matter, subgingivally. Available on the market. I think resin modified GAC is potentially one very commonly available product to use, or zinc phosphate. It's a bit of a dying breed to use zinc phosphate, but under the right mixture and under the right hands, that can be an excellent material to use as well, subgingivally. So now that we've covered post-space preparation principles and the actual clinical steps involved, I think let's now go on to different materials. All right, some of the questions that you guys have been asking are also pertaining to materials. So let's start off with direct posts. We all know that there are direct posts and there are indirect posts. And so let's start with direct posts and start with metal. Because that, for example, the parapost system, right? That's something that as an undergrad, I think we all have used, or at least we know, and perhaps by number of posts sold, is certainly perhaps still the one of the most common post systems out there. So so we should make a discussion on that. So Johnson, if you don't mind, cover with us direct post and in metal.
Great, thank you, Ben. So metal posts can be classified into active and then passive. Active or the threaded posts maximize retention by actively screwing onto the root. But unfortunately, as Dr. Zoe Potres was saying, this post has the 20 times more increasing risk in root fracture. And it's reflected on the 50% survival after a medium term of 5 years. Majority of these failed posts, the teeth have to be extracted due to root fracture, and hence the recommendation is to avoid this post. The other type is passive post. So they are the long serrated parallel metal post. The most common one is available in stainless steel and titanium. The titanium have a lower modulus of elasticity, and then in the smaller diameter, just not as strong as the stainless steel. They do have a very good medium-term outcome, 92% survival. They perform even a little bit better than the customized cast tapered post. So for the customized tapered post, they do not engage in the, they do not maximize the post length, and then have a more reduced stress distribution, and that have perhaps contributed to the lower survival. In terms of the cementation of this post, you can use a resin modified GIC, or some practitioners prefer to bond them in, but you do have to consider the retrievability should you the tooth require endodontic retreatment.
Johnson, if I can interject and ask a question from the floor, and this question may be a little bit premature, because I know that in a moment we're also going to be talking about indirect,
yes,
as in cast gold usually,
yes,
post and course. Now, but the reason why I'm want to ask this question now is because the study
yes,
that you previously made a mention of, they
yes,
were comparing
yes,
a direct parallel post,
yes,
to a cast,
yes,
tapered post. They're not exactly comparing apples to apples, because
no,
right, that you got parallel, you got tapered, you
that's
got
right,
you got direct versus indirect. So there are a couple of things that
yes,
they're testing out. But the question is, material, which is better, gold or titanium / stainless steel? So again, it's hard to, I think, sometimes answer that, because
Yes.
when you're talking about gold, I know I personally don't know any direct gold posts.
Yes.
So as soon as someone says a gold post, I just automatically assume it's a cast post.
Yes.
So in other words, I think this is more a question about what's better, cast or prefabricated metal post, given they're all metal. Do you have based on that article that you just shared,
Yes.
what are your thoughts on that selection process?
Sometimes it's difficult to tell from the article. Do they select the cases well, fairly? You know, so a lot of times in the literature they select cast posts when there's no ferrule, and then they select prefabricated posts when there's a ferrule. So that didn't outline the selection criteria. So ferrule is one issue, but also you have the canal configuration is the other factor. If you have more circular, more parallel, then prefabricated post is good. But if you have more tapered or more different canal configuration, then cast post is good. Yeah, but over the long term, the cast post does perform better. Yeah,
When all things being equal.
when all things are equal.
I'm assuming.
Yes.
Yeah.
Yeah.
And why is that? Do you think?
One thing is it provides the best fracture resistance, and then one thing is it relies on the better adaptation to the canal, so less cement space, because all this cement can degrade over time. Yeah.
Right.
Yeah.
Most of the studies that I come across when they're making these such comparisons, they're assuming if you have adequate ferrule, then the longevity of a direct metal versus an indirect metal, it's more or less the same. They can
Pretty
all
much.
perform really
much.
well in the long term.
Yes.
But if we're talking about a tooth that has no ferrule,
Yes.
pretty much like that article that you stated, I think, and usually you find cast post and core fail horribly
Yes.
because it's just splitting roots left, right, and center.
Yes. Yes.
Yeah.
Yes.
Yeah.
Agree.
No, thank you.
Thank you. The advantages of the prefabricated post is, unlike cast post and cost, you need to take impression, send it to the technician, and then most of the material is made either semi-precious or full precious. Both are very costly nowadays, so require more time. And the prefabricated metal post is got a higher resistance compared to the fiber post. The other advantage is it's available in the smaller diameter of 0.9 to 1 millimeter. This can be beneficial in the smaller canals, for example, maxillary lateral incisor, mandibular incisors, but also in the more calcified canals where you don't want to enlarge the canal more to increase the risk of root fracture. For the fiber post, the tapered version often come in 1.14, 1.15 or 1.25 diameter. The parallel fiber post do come in a smaller diameter, but some people may think the fiber post in 0.9, 1 millimeter may not have the strong enough fracture resistance. The disadvantages of the metal post, as the dentistry is moving towards more aesthetic dentistry, some people are maybe concerned about the metal showing through, resulting in not as a good aesthetics, or when the metal is showing through, they require a more opaque ceramic crown to cover the metal post. When you have a more opaque material to cover, the final result will not be as good. The other disadvantages of that is it requires potentially, because it's parallel post, so it requires more dentine removal compared to tapered post. And then the other disadvantage is the post, if the configuration of the canal is tapered, then the post will be swimming in the large cement space as well. When we compare rigid versus non-rigid post, when we compare the modulus of elasticity in here, we can see the difference of metal post and fiber reinforced or the non-rigid posts, which is quite significant. There's almost 10 times the difference between stainless steel versus fiber reinforced posts due to the mechanical difference, therefore affecting how they behave under load. For the rigid post, the biggest advantage is they do not bend and fracture easily. It protects the crown margin from basically deformation. It's basically ensure the survival of the crown is excellent. But the biggest disadvantage is when the post is so rigid, where is the stress going to go? So the stress is going towards the root, the apical area, as we can see in the FEA image on the right. The red stresses indicate there's more stress in the root area. So for the rigid post, it's very important to ensure you use the parallel version to reduce the risk of the root fracture. With a non-rigid post, I mean, people are looking towards a post that has a very similar modulus of elasticity to dentin. Dr. Zoe Potres mentioned before in structural sound when there's sufficient ferrule, the loading, the post and the tooth flex at the same time reduces the risk of root fracture. However, when there's no ferrule in structural compromise cases, all the stress would be in the crown margin, resulting in micro leakage, which can lead to endodontic complications, debonding of the core or debonding of the crown. So there's much more cost involved, although the tooth have a higher survival rate, but then the patient have to pay for the retreatment of the endodontics or a new crown. Regarding the survival of the rigid versus the non-rigid post, the long-term survival is actually much lower after about 8 years. Most of the study shows the prefabricated posts have a pretty high survival of 90% around the medium term of 5-6 year mark. But however, in the long term, the survival of the titanium being more rigid is higher compared to the fiber post. That is due to the fiber post flexes under load, whereas titanium does not. But it is important when it comes to your post selection to ensure you select the right post, but also to ensure your post, when it's cemented, there's not cemented in a sea of cement, because over the long term, the cement does degrade over time, especially for resin cement. And for me, titanium post is more beneficial compared to fiber post when it's under loading as well. The study shows that the failure rate is higher for fiber post if it was an abutment for a bridge, or if it is an abutment for the removable partial denture, and also have a lower survival for bruxes as well. Yeah.
So I have a couple of questions. I mean, when you show a study like that,
Yes.
it's very concerning.
Yes.
Because it shows that the fiber post, I'm like, good God, right? It's like pretty close to 50% failure after 11 years. Like, who else would use that? So I think sometimes, in that particular study, do you recall that the author stated how much ferrule did these teeth have during restoration?
Although they mentioned 2mm ferrule were able to be achieved in all these situations, but I would say 2mm ferrule is an absolute minimum in clinical sense. So I mean, I do see a bit of a higher survival normally with the fiber pulse, but with this study is a little bit concerning. So I do not, although they mentioned 2mm Ferrule, but they did not show any pictures or any radiographs. What is the 2mm Ferrule and whether there's a sufficient thickness as well. But also because this is done in the postgraduate setting, so a lot of these teeth were supporting as an abutment for bridge and also for the removable partial denture. Although they didn't really report on bruxism, but I mean, basically with my own experience when I did a postgraduate study, almost all the patients are bruxist. They have some sort of wound dentition. So if you have a lot of population leaning towards that, then of course the survival rate is quite low. Yeah.
So in your experience, now that you've gone through some literature, some pros and cons, when would you consider using a direct metal post?
I would use it when I have a more narrow canal and also under high loading cases.
So let's separate these two concepts. You got narrow canal. Now, why would you want to use a metal post?
So metal post, is available in 0.9mm, 1mm in calcified canal where you don't want to enlarge the canal furthermore. This can be very beneficial because fiber post is available in 1.14, but a lot of the system is available in 1.25mm.
So in other words, not only you want to reduce the amount of dentin removal by using a thinner metal post, but also perhaps it's more rigid.
More rigid,
right, as opposed to in thin sections anyway.
Thin sections, yes.
Right. And the second concept of when there's a heavy load,
yes.
So would that be like in a molar situation? Or,
in a molar situation.
Premolar perhaps?
Yes, and then also abutment for either removable or fixed dental prosthesis.
I think you bring up a very good point because in clinical dentistry, there are a lot of situations that it's not just pertaining to the actual tooth per se. Sometimes we do have to take a step back and assessing the full mouth altogether. For example, a couple of factors that you mentioned, Johnson. One is dental parafunction.
Yes.
So if, in other words, bruxism, or when a particular tooth is going to be used as a abutment of some sort, whether it's for fixed prosthesis like a bridge or removable prosthesis, then you're going to have more load. There are many other clinical situations I can think of, for example, being the most distal unit, lone standing teeth, right? All of these would have more stress.
Definitely.
And therefore, your that may change your decision in terms of whether to use a post or not and what type of post to use.
Definitely.
Yeah. Okay. Terrific. Here's another really interesting question to challenge all of us.
Yeah.
Now, so this question is pertaining to upper incisors. They're going to use a post, but they're concerned that the post alone it's not going to be retentive enough. So the question goes, would you consider placing extra pins, stainless steel pins, I assume, lingually and buccally? What's the panel thought on that?
Well, what's the retention for? Is it to retain?
To retain the core.
For the core. So in that case, if the tooth is structurally compromised to that extent that it's requiring the post plus pins, then in that case, I would actually consider a cast post core because it's coming as one rigid unit, and you don't really need to worry about building up a core. I mean, that's the problem with having the prefabricated one is if there's not enough tooth structure to hold the core, it's quite a difficult situation to try to form that core and make sure that it's going to bond to that little retentive features in the post if there's nothing else to hold it in place. So I wouldn't go for the pins. I would go for a cast.
Yeah.
It's interesting. So very rarely do we employ pins these days in restorative dentistry, as we know that during the pin placement we can actually introduce some stress in the dentin. But throwing back a question to the audience as well, I have actually encountered a situation where I have used pins whether these pins is to, and they are placed buccal, lingually, or where I can deem there is a bulk of dentin. However, these scenarios are actually on non-endodontically treated teeth that had some horizontal fracture or quite broken down one dentition, typically in elderly patient where the canal is so sclerosed and there is actually no indication for endodontic treatment. So in those scenarios, you really have to weigh up, am I going to seek endodontic treatment to create a post space? Is endodontic treatment at all possible or have other difficulty? And to arrive at a situation where, well, you know, if there's absolutely no indication and the area is so sclerosed, which means in the cross section you have an abundance of dentin, and you can actually therefore quite reasonably allocate these pins. Then in those, you know, extraordinary scenarios, I have utilized pins, whether it is just for a composite crown or further into doing an indirect restoration, leaving those pins anchoring as a core. So that is something I can share. So it's actually on non-endodontically treated teeth with no indication for endodontic treatment and looking for auxiliary retention form.
I'm actually surprised you could actually find pins at the Westmead Hospital.
Can find many things there.
I thought at the Sydney program, pins are almost like a swear word.
Yes, but so that's why I say it's quite extraordinary cases.
Yeah.
But, you know, there is always, you know, particular indication where when you use something that's non-conventional, is actually there are particular reasons and indications for, and it all comes down to case selection. Yeah, which I think.
Terrific.
Yeah.
And of course, we will be talking about the cast post and core that Zoe has mentioned in a moment. So thank you, Johnson, for covering direct or prefabricated metal posts.
Yep.
So now let's go to the next subtopic, which is prefabricated fiber reinforced posts, because that's really gaining a lot of traction. It's becoming very, very popular. I'm sure the panel here primarily are now sort of swayed more towards fiber posts rather than metal posts these days for a number of reasons. So Agnes, could you cover for us, you know, what are the pros and cons and what are the indications for fiber posts?
Thank you, Ben.
Thank you.
Okay, I'd love to do that, but before I actually dive into looking at the fiber post aspect, I just love to recap on, like, you know, because like you said at the beginning, the reason why we have touched on the Ferrule aspect multiple times is because when we, at this point, when we have a very rigid post versus non-rigid post, and in the area of choosing whether we do need a pose or not need a pose, and it's almost like a big rewind back to how I started the topic on scenarios without pose, because I just feel like I need this recap as I see the types of questions that are coming in. So going back to the choice of the decision on needing a pose is really just to retain a core. So in summary, there are a lot of bonded dentistry these days where there is a very good enamel in different definitive preparation, that the enamel is the retention form. And therefore, in those scenarios, quite typically, there's no need for a post consideration with the remaining intracoronal restoration as a core, so to speak. So we can move on. But even as we flow on to talk about post selection between rigid post, non-rigid post, metal post versus fiber bonded post, we come to this discussion of Ferrule, and basically it's because if we have a tooth with the root and we have now a very rigid post, it all comes down to lateral load, whether that lateral load is parafunction or abutment or bruxis, or it comes down to the lateral load received by this tooth, and now the tooth is undergoing flexion. So what happens to the tooth root and a rigid post is that the rigid post, like this palm of my hand, is rigid. It doesn't bend. And when there's lateral load applied on it, this whole beam is trying to flex, and therefore it will push on the remaining root until perhaps the failure mode is a root fracture. And of course, there are much to consider as Zoe has gone through all the root preparation in terms of the quality of the remaining root structure or the thickness that is remain, or that whole surface area, that adaptation that we can apply this force upon. But as we move on to what I'm about to discuss, which is the fiber pose, and why we're still talking about Ferrule effect, is that when there is a non-rigid pose, so same thing, now this palm is non-rigid, so it can bend, and it's going against the intracoronal canal. So what is happening now is that instead of the whole movement, because the pose can bend, it's now creating that gap, which is what we're concerned about in terms of the post debonding, or that marginal seal that is going to jeopardize our restoration. And that is why we're now talking about that ferrule in that cervical area, because that is what can resist that lateral bend or flexion within the tooth itself against lateral load. And arguably, as I will go through with you quite interestingly, is some study that look at adhesive restoration as well, because on the contrary to the Ferrule effect, are there any additional retention form from enamel bonding against this potential flexion within the tooth from our restoration? So let's have a look at our study here. Flowing on to rigid and non-rigid pose and the metal prefabricated pose by Dr. Johnson, let's have a look now at the data on fiber pose. So in the Ferrari study in 2000 and even at around that time, he compared and looked at the failure rate and the failure mode of different poses. And actually, fiber pose didn't do that bad at all. Like that at that time, it was sort of something sort of more emerging at the time compared to the armamentarium of all the metal pose that were around. So metal prefabricated pose had an annual failure mode of around 2.1%. And comparatively, in the fiber pose, the failure rate is around that 3% mark. So it is only in the very short term, up to 6 years at the time of most of the studies that were critiqued and available, but it was doing very comparably compared to the other pose system that were around. Now, when we are looking at this now, looking for something a bit more longer term data, and Johnson's already presented one, but there is another study that came about in the recent Journal of Endodontics in 2017 that looked at teeth that have been restored with fiber pose for up to about 11 years. The mean was around 8.8 years, so close to 9 years. And the data is quite interesting. It was done as a retrospective study looking at 144 units of teeth. And all these teeth were restored in the one specialist practice, and the specialist is both a periodontist and an endodontist. So he followed the criteria where subsequent to the successful endodontic treatment, when he comes across teeth that had only one bone left, or teeth that had less than a third of the coronal tooth structure left, he would put in a fiber post. And he had quite a strict adhesive system protocol that is being documented. Now, each of these teeth, though, is then be restored either with a direct composite resin or a single crown restoration. So these teeth, as you can see, goes across the arch, and he has documented how many incisors or premolars, maxillary molars, mandibular molars. But in this particular study, it actually made several claims that was rather interesting. One of the claims that it had made was that actually whether they were restored with a fiber post or contrasting the number of cases that were restored not with a post, is that they compare quite well against each other. And there were actually incidences that is reported in vertical root fracture even in cases that did not receive a fiber post. They also reported that whether it was, in looking at the teeth that were restored with the fiber post, the study reported that whether they have a direct composite restoration versus a crown, they both do equally rather well over that 9-year time frame. But one of the things that I would like to highlight here is that this study really failed to identify whether in the direct composite group, what type of restoration did they undertake. I'm sure maybe there would be an abundance of enamel to adhere to, that hence they feel that the final restoration can be in the composite resin. But what it really failed to report is whether or not they had full cuspal coverage, as well as the type of occlusal scheme or the occlusion that are in this study, because of the whole notion of the reported cases without fiber post and resulting in the root fracture really flare up some concerns in terms of, I wonder how the case selection or the occlusal parameters or other risk assessment had been processed through to be included in this study. But one important thing that I feel I could quite safely draw on to is that in the group that, because they did have quite high numbers, it's like close to around 100 units of teeth restored with fiber posts that they review. While both direct composite resin group and the single crowns do quite favorably, is that there is significant higher success and survival rate in the single unit crowns that are provided. So, but what we can guarantee or assume here is that with the crown unit is there is some sort of Ferrule. Maybe we don't know how much Ferrule, but there will be some sort of Ferrule, as well as the fact that these crowns are definitely having the full cuspal coverage. So that significant difference of improvement is, what we think is still have relevance and still have importance, even when we are using fiber post situation to be restoring dentition. I would feel that the data reported in the non-post scenario, while there is still about 40-50 odd teeth reported in this study there, you can't really draw a comparison between the direct resin group and the crowns, because I think indeed for perhaps from a tooth conservation or the tooth structure assessment, there are much fewer units of teeth in this group that resulted in a crown fabrication. So hence I do not actually feel there is too high validity in the conclusion they draw on that aspect. But definitely it is one of the more recent study in a high impact journal that is very interesting, and I'm glad I'm able to have some discussion tonight on this about it, because there are some relevance to how we interpret the data and ties into tonight's discussion. Let's share a case of a fiber reinforced post that we use and we consider in this scenario. So this is one of Dr. Johnson's patient, actually, where he had seen the patient coming in with original Emax splintered crowns that had fractured in the connectors, as you can see, between the canine and the lateral incisors. Upon removal, you can see that these splintered units are in a case scenario where there is quite a deep bite. The original crown form is also got a quite high degree of taper. It is in the anterior zone, and we are about to embark to consider how we're going to help this patient replace the definitive work subsequent to the previous failure. As we assess the tooth structure, this is a picture that you've seen before where Dr. Lee had already discussed while there is all four wall present, the existing buccal and palatal wall is quite thin. So this scenario, the tooth, especially around that cervical portion where the tooth may receive some flexion in a case that we know it's already got that deep overbite, so there's going to be a lot of lateral load, would benefit from having some kind of post in that intracoronal space. When it comes to the post consideration, this is a very good illustration of comparing will in a prefabricated situation, because in general look, the canal configuration is quite round. We have convenient armamentarium that we can do in single visit. That's the advantage of a prefabricated post. We still have a choice between metal versus fiber reinforced. So with this X-ray here, you can see and compare that with your standard metal post that is of a parallel post. As Dr. Johnson had correctly indicated from before, unless your original canal is rather sclerosed, meaning that the canal space is very fine, as well as the fact that perhaps it means that you have very good root thickness across that length of the root, would you consider preparing that space to engage a parallel post, because it does inevitably involve more root surface removal? And is there benefit of doing that? Well, in this particular case, even though it is a deeper bite situation and we are considering high forces, we can't really afford to do that, because as you can see on this X-ray, if we were to do that, the remaining root structure on either side of that prefabricated post would become rather thin. And remember what we discussed about is that while the advantage of having a rigid post, as long as possible, good surface adaptation can resist the tooth much better and more favorable in a high loading situation, we still got to be pragmatic and look at what tooth we have. We're not going to do that at risk of compromising the root structure and going past that 1/3 of the cross section at the apex, at the tip of that post, to make it more easy to have the root fracture. So in this scenario, you can see on the X-ray, the fiber post being in that tapered configuration is much more suitable. With the fiber reinforced post, it also has the added advantage of being having that ability to bond onto resin, and also more favorable in terms of aesthetics, not having any metal showing. And Dr. Johnson has been able to then place the fiber post into the clinical scenario and further improved on the existing crown form, so that the core now, as you see it, is much more better in terms of resistance and retention form. What is also important here is that now the crown path of insertion is quite different to the path of insertion of the post being cemented on before. So all these thought process had been through together to yield this final restoration of having non-splintered unit and be able to deliver the result that Dr. Johnson had. And even in post-op 5 years, has been very nicely done. And of course, he paid a lot of very careful details to his final occlusal scheme and follow-up patient instruction, because in the end of the day, aside from the type of post that we choose, aside from the type of preparation that we utilize, it is still about minimizing that lateral load, both in our restorative consideration as well as the final occlusal scheme and that patient education process. So we see here that while in a nutshell, we can consider that the fiber reinforced prefabricated post can have a general indication when there is at least 2 millimeters of supragingival tooth structure available. And the reason for that is whether it is for ferrule or whether it is for existing enamel that is available, that additional retention mechanism between your final restoration and the tooth to resist any bending moment of the tooth is critical for any fiber reinforced bonded post to minimize any marginal adaptation issue and to protect that integrity for that root canal system, as well as combating risk of secondary caries or any other such complications. And of course, having the ability to isolate, having more surface area and minimize any tooth removal is an advantage. So advantages, as I before mentioned, also it is very accessible, single visit, much lower cost for the patient, better stress distribution. But it is only a favorable and a good advantage in utilization of tooth that, at least in the cervical remaining tooth structure, has a favorable and what we consider still quite structurally sound compared to very, very decoronated tooth that we are more concerned about having that ferrule effect. Some of the disadvantage is that, the earlier generation of the fiber reinforced post does have more limited visibility, but more and more now there are radio opaque version of the fiber reinforced post available. There is some limitation in terms of the adaptation for canal configuration that have a larger cement space. However, arguably there are different techniques that, which in the end it doesn't change the fact that this is still a resin bonded post, but there are other techniques of using multiple posts, almost like having additional lateral condensation type of thing to fill the canal space, or things like ever stick to adapt to have a bit more customized post. But in the end of the day, it does not change the mechanics of the fact that it is a fiber reinforced bonded post, and that ferrule or lateral load and how the tooth will resist any bending. All those principles still applies. And the final note is, of course, as you're using these fiber reinforced posts, is important that as you modify the post, is preferably to use a metal disc rather than in general a burr or a scissors clip, so that you don't damage the fiber. And for those of you, which we didn't go through in depth today, the general consideration on dentine bonding, the quality of the dentine, how we actually go through the dentine bonding process, etc., we can go through our past seminar about those. But at this point, just a recap is that sometimes we are faced with teeth such as this, which after the endodontic treatment, this is how we receive the tooth back. In this scenario, the endodontist has already provided us with the post base, and there is apical seal at the base of the canal. And in my opinion, I feel more and more comfortable these days to actually let my endodontist colleague to be providing me the post base, because that is actually the best timing to actually, I prefer them if they feel comfortable enough. They are the one that cement the fiber post for me, even, because that is the timing for this procedure to take place at best. But sometimes without the prior communication or the tooth assessment, there is that communication as to, well, what other retentive feature could there be on this tooth, as to whether or not, you can't just by default say, hey, do everything for me and I just come back and do the crown. No, there is that thoughtful process in between time. But for the webinar tonight, let's have a look, because what we have to now visualize, due to the proximal boxes being quite deep, again, this is the outline that I spoke to you at the early of the opening. So while that buccal wall seems to be quite thick, remaining in situ, once we do a crown prep on this, it's going to be quite thin. So in this case, we have decided that, using a fiber post will be useful. So we have to, under good isolation, after etching the selective etching of the enamel, as we apply the prime and bond, we have to really rub it in and really allow it to just flow into that dentine as much as possible. And then perhaps I don't really air dry it, but I would use some paper point to remove any excess of the bond that is in the system. The fiber post that we have already pre-measured to size, we would be putting in a dual cure cement, and as Dr. Zoe has mentioned before, there is that pumping action to encourage the flow of the cement to be extruded through the vent space. Hold it very still. And with dual cure cement, it is important that once we do the spot curing initially, to allow, like, you know, no movement, no preparation, just and no further curing, just to follow the recommendation of the dual cure cement setting, to allow that chemical set to happen for whether it's 2 minutes or 4 minutes for some, because you don't want to have, you know, straight away put the light cure onto it as well, to furthermore of that preliminarization shrinkage. So do follow whatever material you use on the recommendation and the manufacturer, and be mindful of this wait time for the chemical cure to initially achieve its set, and then of course finally curing it. And then from here, you'll be able to then visualize the different color, again, between your core material and the final tooth structure. And they're quite easy to cut, these core paste or you know, typical core material. So they cut like butter almost. And you'll be able to also visualize the finishing margin at the apical border of your restoration, so that you can ensure there is going to be good Ferrule of that minimum 2 millimeter that can be on offer, and completed with the final restoration. So I guess, like, you know, I have this slide to just touch really briefly on the ceramic post. So typically these are of zirconia material. Again, they will come in prefabricated or or customized mills type scenario. While they have the advantage of being very aesthetic, they pose a challenge of them being highly rigid. So just like people would say zirconia is like a white metal, you can almost consider this like, you know, they are highly rigid. And what that does mean is that it can, in a cast post core scenario, or even in just a rigid prefabricated post with a lot of bending moment, they can have a high incidence of rib fracture, and the fracture will happen, will be directed more apically, as would anything that is with increasing rigidity. Anything that actually is non-rigid, like, you know, on the other end of the spectrum, not to say that things won't fracture, but they tend to encourage either 1, debond, 2, if any fracture is to happen, it's a bit more oblique or horizontal on a tooth level, or 3, if the fiber's been damaged or whatnot, then the post can fracture instead. And as Dr. Zoe have already mentioned as well, it's a pain for anyone who has to consider removing the ceramic post. It's almost impossible. And in prefabricated scenarios, also bonding the core onto that post is also an issue. So most often, people who may be considering this is still thinking about, like, you know, the mill type of zirconia post core. So that would be my very brief discussion on the ceramic post, because personally I don't use them. And on this note, I'm going to pass to Dr. Lee.
Thank you so much, Agnes. And again, there are some questions asking from the audience again, asking pretty much along the lines of, would all endodontically treated teeth be better served with a crown? And the answer is no. We've covered at the beginning of our webinar extensively. Not every endodontically treated teeth needed a crown, and there's definitely, you do, as a clinician, you do have to weigh up your decision-making process and when perhaps a crown is not indicated. And this particular webinar is not geared towards a restorative decision-making process as opposed to post and course.
Yeah, we have another earlier webinar that actually talks about decision making on your definitive restoration, which is actually based not just on the remaining tooth structure or endo treated or not, but aesthetic, functional needs, are the means.
Brett, is that particular case ready to go? Terrific. So, having discussed the use of fiber reinforced post Agnes, here is a case that's sent in by our audience tonight. So we all have to, is now really putting us to the test. So the clinical history is that this is a 55-year-old lady. After root canal treatment of what appears to be tooth number 22, a fiber post was placed. The clinician did say that she did not extend the post long into the root. It was cemented using a dual cure cement, Panavia 5. Subsequently, there's a composite core. A zirconia crown was made and cemented also with Panavia, so dual cure resin. The clinician prepared the crown subgingivally to have what they recall was adequate ferrule, but they don't remember whether it was 2 millimeter or less. Unfortunately, after the restoration, the patient bit on something hard, which broke/displaced the crown. So something has moved. Now we don't know what exactly it broke. Is it only the core, or is it a bit of the tooth? We're not exactly sure. But they said that you can see on the PA that there is a horizontal fracture which has broken the post. So I assume that's the that's that black line, which is a little bit above the crestal level, but not that far away, I'm guessing. So the clinicians now have to make a decision. Now they have not removed this crown yet because it's still somewhat could be mechanically locked in place, or is it broken a little bit more deeper that's attached to soft tissue? We don't exactly know, but they're asking the question is, should we retreat this tooth, as in with a new post and core and a crown of some sort, or is this case better with an extraction and potential implant replacement? What does the panel think?
On the distal part of the root canal, is there another fracture line below the initial fracture line?
It's very hard to see, isn't it?
It's hard to see.
Yeah, we're not exactly sure. But I guess we could say best case scenario, worst case scenario. From what I can see, best case scenario, if this was a reasonably horizontal, maybe slightly oblique type of fracture, it does appear to be somewhat subgingival. Most likely crestal, according to, it's a two-dimensional radiograph. It's always hard to say exactly how oblique or how subgingival it is, but assuming it is 1.5 millimeter supracrestal, but otherwise subgingival, it's very hard to restore in my opinion. There's not much ferrule circumferentially. So to obtain enough ferrule, I would think either if you can be if you can convince the patient to carry out some sort of ortho extrusion, because that lateral root is fairly long, a lot longer than most laterals that I've seen. Now we don't know how that PA is taken. Is that PA elongated? I don't know. But again, assuming, I have to make a lot of assumptions here, that PA is reasonably parallel and it's just it's a great long lateral incisor, that you got some meat to work with, potentially with some sort of ortho extrusion, and then you got to go through the whole process of some sort of post and core. It's a lot of work towards one particular tooth. I guess ultimately you have to have a discussion with the patient about whether the patient feels cost-effective wise, is that still value for money for the patient at the end of the day? Because it is a lateral incisor, and we know that statistically speaking, endodontically treated lateral incisors, when you restore them with post and cores, they carry the highest failure rate. There's been shown a number of studies. So that I think we have to take into consideration. What does the rest of the panel think?
Yeah, I think in this scenario as well, thank you so much for sharing this case because it does go to show that even with the fiber pulls, even though it is bonding it in place, etc., this flexion does occur, and it doesn't negate the fact that you still have to apply some of the original principle in the post preparation to get a longer post. And so thank you so much for acknowledging that and also sharing the case with us, because that is and perhaps with that post fracture, I'm not so certain whether you recall as you shorten that post whether you did use a metal disc or not. It is mindful to not damage those fiber posts, that fiber as one point also. Looking at your radiographic share of the case, in the pre-treatment radiograph, we can actually see that fracture line is more or less similar to where that distal restoration perhaps actually is finishing. So, whether or not there is good Ferrule, again, I would really encourage in future to use a core material that is a bit quite different to your original tooth color, if that at all helps you visualize how much you're going beyond. And often, do your periodontal check and bone sounding check to assess actually how much further you could do in terms of your crown preparation versus consideration that Dr. Lee had put forward orthodontic extrusion, or if there's any crown lengthening, but how this may impact on the aesthetics. But in terms of a retreatment, to answer your question briefly, I think it is very difficult, because you're also considering that you cannot retreat this scenario unless you will be removing the existing short post inside as well, on top of all the other consideration that Dr. Lee had gone through. And invariably in that process, you may or may not, ascertain any, aspect of potential factors that affect the previous endodontic treatment in terms of further mechanical preparation for a longer post, or in that process, exposure to the oral environment again. And in the end of the day, you're back down to a very compromised tooth and very high risk for further mechanical issues as well as other biological issues. So I think it will be a very difficult retreatment case.
There's another question, which is, could we consider crown lengthening to, I guess, increase the amount of tooth structure under Ferrule? My only concern with an anterior tooth, when you crown lengthen, is aesthetics. Now, you are invariably, that clinical crown height for that individual tooth will be significantly longer than the rest. Would that have any impact in this scenario? Another thing is that these lateral incisors, that space is quite tight. So whenever you are carrying crown lengthening, you're invariably removing the bone of the 21 and the 23 at the same time. So you're almost crown lengthening that whole anterior region, and you're going to lose some soft tissue there. So would the patients be okay by the end of that? So all of that needs to be taken into consideration.
And I think it's also a good, very good case share for us to share with you. Aside from considering our occlusal scheme in the anterior zone, as we work with teeth that has been post-core treated and quite compromised, perhaps you had thought that, this tooth is not in so much lateral load, is being protected by the canine, etc., etc. But don't forget that unless you are mindful to actually instruct your patient from here on, please don't snap bite on an apple. The function of your anterior teeth is usually bite and tear. So inevitably, even if you do think about your occlusal scheme, or they are wearing their occlusal splint at night, there is that additional information is really, you just have to minimize any lateral load onto that system, balancing of course on how compromised they are.
Absolutely. Yeah. Thank you, Agnes, and thank you for all the wonderful questions you guys been sending through. So keep them coming. We're now going to take a small deviation from our topic. Now, I know we still haven't gone through cast, post, and cores, but for now, we're going to talk about cores because we have to make a mention about cores in the topic of post and cores. So, if you don't mind, Zoe, could you take us through the different core materials that are available?
Okay, I'll just briefly go through the core restoration. So again, the idea of having a core is it has to just remember that there's certain design features in your core. So it is equally important to putting a good post in place. This is finishing the job before putting the crown on. So the core still has to have that retentive features that prevent it from vertical displacement of the crown. Plus it has the resistance against any axial forces that might try to displace the crown again. So it needs to incorporate some sort of element into your core features, whether it's interproximal grooves or boxes, maybe the occlusal isthmus, maybe creating some sort of grooves on the occlusal to help aid that sort of retention and resistance. Now the other thing is the height of that core, minimum requirement 3 to 4 millimeters at least, to give you that sort of resistance and retention for the crown. Convergence angle at maybe approximately 6 degree, 2 to 6 degree in terms of convergence, to aid again in the features of the crown. And once we build up the post, then we need to look into do we have that adequate ferrule of 2 millimeters, because it's and if we don't, then maybe we should incorporate that ferrule, whether it's with the crown lengthening or going slightly subgingival preparation to incorporate that ferrule as well. So cores, basic, they're pretty basic. We all use them every day. So we have the amalgam, which is a high compressive strength. It's quite rigid. You can bond it as well to the restoration, so to the tooth structure, versus the composite, which is a bit weaker in terms of physical properties, but if you have a considerable amount of tooth structure remaining, that it is a good versatile material to use. It could be dual cure or could be some sort of syringeable, so it's an easy material to use. The glass ionomer material is a bit more has kind of a poor performance because of the properties of the glass ionomer. So amalgam, there's a lot of advantages to using amalgam. First of all, it's not really technique sensitive. You can pack it. It has really high compressive strength. Initially though, it does need a bit of time to set. So initial tensile and compressive strength are quite weak. So we need that second appointment to come back and prepare. So it's increasing our appointment time. Some patient might experience that galvanic reaction from the amalgam as well. And plus some patients may have an issue of having a mercury. But amalgam is very strong and can be used mostly in the posterior teeth because of the aesthetic concern anteriorly. Composite here, there's a lot of advantages to composite. It's in good situation where you have really adequate moisture control, then composite is really good material. It's very strong, even in thin section, versus the amalgam, which we really need a good bulk of amalgam to achieve that strength. The amalgam is a bit weaker in thin section. So composite, it sort of bypasses that. There's no mercury, it's tooth colored. It's ideal under all ceramic restorations. But if the moisture contamination is an issue where we can't really use rubber dam or we can't achieve good moisture control, then there's always that issue of adequate polymerization, and then it might be possibly polymerization shrinkage. So we have to be careful in choosing the cases that are suitable as well. Glass ionomers, it's a lot of studies have shown it's really not very strong to use as a core build-up material. We need at least 2 good remaining walls of tooth structure to be able to use the glass ionomer. It is also moisture sensitive, especially like wireless setting to sort of water. So glass enema is probably in a lot of the cases that do require post and core buildup. Maybe they're not really ideal core material to be used because a lot of them are structurally compromised. This study I would like to share with you in terms of the importance of having some sort of a foundation restoration. So they looked into 6 different sort of scenarios. And they divided them into 2 groups. So the first group where you have like teeth with no foundation restoration. So there's a remaining tooth height of 2 millimeters, 3 millimeters, and 4 millimeters. So these are the 3 tooth no foundation group. And then the other group, second one, they also had the same parameters of remaining tooth structures, the 2 millimeters, 3 millimeters, and 4 millimeters. But this group had also a foundation restoration, which that corresponding height of 4, 3, and 2. So achieving the total foundation height of 6 millimeters totally. The 3 groups also had a post that's of equal height in all of them. So that they about 8 millimeter long. So if a tooth had 2 millimeter structure, the foundation will be 4 millimeters on top of that. And the 4 millimeter tooth structure, 2 millimeter foundation, post retaining all of them. Now with these, they subjected those teeth to a fatigue load. I think it was something around the 58 Newton, and they applied that forces at 135 degrees to the long axis of the tooth. And what they found that from the diagram they can see here, the teeth that did not, the more kind of vertical remaining tooth height or core height, the better the tooth survived. So there was a larger number of cycles before the actually tooth failed. But the teeth that had foundation on top of the remaining tooth structure, they performed the best. And that kind of came up to the conclusion that having a foundation is you're actually increasing that resistance, retention form, improving the stress distribution, and eventually probably increasing the survivability of that tooth in the long term.
I did actually find that quite surprising. You know, I thought previously if you had 4 millimeters of height, well, that's enough. Just go for it. Put a crown on it, right? What else do you need? But that study, or at least in vitro, has demonstrated that having a core, even on top of that, actually is helpful.
Yes. Okay, so I think that's a good sort of case to finish on, Ben, before I pass it back to you.
I think there's 2 other potential situations that we want to cover. One of which is actually using the amalgam per se,
yes.
right, as an amalgam post and core, which is the Nair technique.
Yes.
And the other is the Endo-crown, which is becoming sort of catching on some popularity, especially intraoral scanning and milling. Many clinicians are doing that, which there's quite a few actually questions regarding amalgam post. So one of the questions is, when is the indication for amalgam post, and is there still place for it? And my short answer is yes. I'll give you the cover in detail. And the other one is talking about Endo-crown. So if you don't mind, Zoe, if you could cover those 2 points with us.
Okay. Now, classically, I think the classical approach in terms of preparing endodontically treated tooth is we always go for a preparation for a post, building up a core, and then the crown. But sometimes that's not always possible because of the complex anatomy. The root canal spaces might be too thin, too short, or too narrow, or they've got unusual curvature or unusual shape, maybe a C-shaped canal or a figure 8 or something like that. That's complicate that scenario. To prepare that for a post, you actually end up removing quite a lot of the tooth structure. Sometimes it can lead to 50% loss of extra tooth by preparing sufficient amount of the roots to receive the crown. So amalgam packed, that's a really old technique, into the sort of radicular space, into the root canal space, is usually 2 to 3 millimeters of intracanal preparation, leaving all the undercuts in the cavity or in the pulp chamber to retain the amalgam and building up the whole restoration. And that can be maybe ending up with a whole crown buildup of amalgam in one visit. So there's a lot of advantages. It's more economic. You're reducing the reduction of tooth structure. You're incorporating your retentive element into that tooth via the grooves and boxes and whatever actually features the tooth has, and packing that amalgam. So it's traditionally been used for many years, and it actually has
It's
a
very
good,
conservative
very
and actually got
conservative,
quite a good track record.
good track, absolutely.
I remember at the quite a number of years back at the Australian New Zealand Prosthodontic Society, there was an internal survey that was asked, what material did people use? And I recall back then, amalgam was still actually voted the most common core material used for molars.
For molars, of course. We wouldn't do that on a central incisor, but yes.
Not many.
But I think, in terms of there isn't so much comparable level of clinical study per se that look at that in detail, comparing. I can just glance at the question, comparing against, for example, cast post. But I do find that whether it is amalgam crown, or whether I think further on the discussion as to using the composite, and maybe a good zone now to answer the previous question of, what are our thoughts of not putting a post there and just extruding that flowable composite, into that canal. It comes down to also your actual restorative technique. So for example, with the amalgam core situation and the amalgam crown situation, it all comes down to how steady and tight is your matrix to ensure that during the amalgam packing, there's not so much moisture and also movement that affects that setting of the amalgam or that movement. Although the good thing is, if you've ever built a very large amalgam crown, if that matrix is moved and it didn't set properly, you will know straight away, and then you will be able to redo it again. Composite, however, you don't know. So going back to the earlier question of, can we just surrogate this technique and apply it into composite? I would say that the basic principle is that you have to understand there is an effect of your cross-section of how thick that material is to that material's strength or fracture resistance. So in that earlier question, there's a lot of assumption because, it's quite hypothetical. It was just like, this is what I generally do.
And it also did not say whether it was for anterior or posterior
so
situation.
If that post space that you're talking about is so thin, and in fact, you actually have a lot of tooth structure for your core, so then you have to consider at one end of the spectrum, what you're doing is you're actually filling your canal space with the composite resin and not so much using it as your post to retain a core. So in that instance, you're really obturating that rest of the canal with the resin. Now versus the other scenario of, using somewhat like this amalgam post, technique scenario. Then you have to consider in that composite, are you using a light cure or dual cure? What we're concerned about is that depth of set. But secondly to it is, you mentioned flowable. Obviously then you understand that there's that continuous set, again, not having any movement or weakness at that junction where it joins onto the rest of the core. And certainly, finally, is that bulk of what is that strength of that connection between what you've just incorporated into part of the core. The rest of it is still, it's still the same principle. Have you got enough Ferrule to resist any further bending? And if it has worked quite well in your hands, perhaps you're quite a considered clinician in your risk assessment to eliminate any lateral forces that is on your particular tooth. But if you, in general, were to ask us to comment on what do you think, like, just as an expert opinion without any evidence base, and indeed there hasn't been any published data of just extruding composite resin or selection criteria on these cases, those will be my thought process into interpreting like what you are doing right now, and but what would be the thing to consider and how it impacts on your final restoration and the outcomes.
Thank you so much, Agnes.
With the endo-crown.
And now I think we want to just have a little chat about endo-crowns, isn't it, Zoe?
Yeah, I think one extra thing to cover with the amalgam cores is the studies that looked into that molar tooth being restored with just amalgam with no post. It has similar fracture resistance, so the teeth don't really need a post. It's just the aim is just to retain the foundation or the core restoration. So they have similar, doesn't affect, it's not reinforcing or strengthening the tooth. Endo-crown, I have to admit I don't do, I've never done them before, but there's certain guidelines that we have to consider, or has been considered in the literature. There's certain guidelines that we need to prepare, and understanding those guidelines will understand the limitation of whether we go ahead and do them for our restoration or not. So I'll just run you through the guidelines and the recommended ones. Now the ideas, it probably began similar to the amalgam cores, trying to preserve tooth structure, trying to do all in the same sort of restoration, having that core and the retention from the tooth. So with the endo-crown, we do need about 2 to 3 millimeter of occlusal height to allow for reduction, to allow for the crown part of on top of the restoration. Then you need the like a shoulder or a margin of at least 1 millimeter. The pulpal floor has to be flat. It's sealing all the sort of endo excesses. We do need to prepare into the canals about 2 to 3 millimeters into the canals. The walls shouldn't have any sort of, the internal line angle shouldn't have any undercuts. So all of those needs to be sealed or eliminated. So there's quite a bit of reduction that needs to be done onto the tooth. And you need to have like a pulp chamber of about 2 to 3 millimeters as well. So depending on whether after doing all of this, do we still have that enough retention in the tooth itself? If it's a tooth that has a long clinical crown height, perhaps that might be a good option. But if a tooth has got a really short clinical crown height and then you're reducing all these extra reductions to achieve the required parameters for the endo-crown, that tooth will be a bit more compromised. So you're really relying on that cement layer pretty much at the end. Now, the recommended material for endo-crown is lithium disilicate and composite, because they can be indirect composite, because they can be bonded or to the preparation. Zirconia I try to avoid because it doesn't really bond. That's not going to work that well. And the majority of cases, if they fail because of the bonding failure. As opposed to anything else. Now, endo-crown is not for every tooth. There's certain teeth that cannot be used because if your margins are subgingival, then you're compromising your bonding strength. So it has to be supragingival. So anything that is subgingival, probably consider an alternative material or alternative restorative option. Also, if it's not recommended for teeth that has that might be a central or premolars or laterals, because of the non-axial loading on those teeth is quite much more significant than molars, for example. So it's only for molar. I think the recommendation is only for molars, and avoided in any anterior teeth. Yeah. I think that's.
Because I think in principle you are. It's almost like an inverse crown, where you're using the internal wall to be your resistance and retention form, and in a nutshell, still it's in molar because minimizing lateral loading,
Minimizing,
to not jeopardize.
but if a patient is a bruxer or like a
Like
really
good
steep
function.
plunger cusps with a really high risk of lateral loading, then that's not even indicated for
No,
Endo-crown.
and I think in this scenario it's more so for perhaps for whatever reason you've decided that your final restoration for this molar is going to be an onlay, and there's going to be enamel, and you only need partial coverage. There's no concern about discoloration of the rest of the tooth in the future subsequent to endodontic treatment. And you know, on that nature, you've already decided that you're going to be doing an occlusal onlay for this molar in all ceramic material. Then you would then maybe perhaps go into, again, like, you know, creating additional retention foam by just putting that endo bit, which is just engaging into the chamber. So it's kind of like an inlay onlay in one go, that kind of concept. But still, like, you know, there will be selective cases to utilize them on if you would like to ensure a good outcome. And it still comes back down to try to minimize any lateral load.
Absolutely. The only, I guess, additional comment I'll add to that is because you're relying primarily on bonding at the end of the day. So there are some teeth which could be sclerotic dentine or affected dentine. So the dentine quality is compromised, and that's partly contributing to why there could be early failures of endo-crowns. And certainly back in my CEREC days, the majority of the endo-crown failed were all these sclerotic dentine type of cases. According to the literature, most literature that I read on endo-crowns, in short term, they actually were very favorable. Had a lot of very good high survival in your short and medium term. I'm not aware of any long-term endo-crown, good quality long-term data available. So that's something to look out for, I guess, in the future. Now, thank you so much, Zoe, on the coverage of course. So to pretty much finish off the evening, the only last thing we got to talk about now is indirect post and course, or cast post and course. And Johnson, do you mind to take us through on that?
Thank you, Ben. So different to direct pause, where we have a good ferrule, good canal configuration. In direct cast post and course indicated when there is insufficient ferrule and canal configuration that is not circular. Well, basically, for anything indirect, you need to remove all the undercuts. So you have sufficient ferrule, you actually need to remove a lot of tooth structure. So hence, this technique is indicated for when there is insufficient ferrule. How does it perform in the study? In this literature, it shows 90% survival with follow-up of average follow-up of 19 years. I mean, this study was done in specialist practice. What's interesting about it is patients attend annual review. So I assume a number of things were checked, including occlusion, because occlusion changes over time. So they can put overloading on the pause and core, and then failure of the crown. So, and the patient is very different. They will be very diligent patients to attend all the annual recall as well. I mean, one of the things I learned is when we treat patients, we need to let them know these are compromised teeth. They can't use it like a normal tooth, and then they always need to be very careful on chewing on these teeth to ensure this tooth lasts them for a very long time. They can't just go out and then crab claws or something like that. But what we don't know about this study was whether there was it doesn't say whether there was a sufficient ferrule or not. I believe with good occlusion control, they can really reduce the risk of root fracture. So there was only 5% after average follow-up of 19 years. Even the 5% that failed, they were in service for 17 years before they failed, and the survival was lower for increased loading cases, such as patients who are bruxers, and also there are abutments of some sorts. The advantage is this has not only has it have a high resistance to fracture dislodgement in cases of not so ideal ferrule, but it has the best adaptability to the root canal, where there is a root canal configuration. But what's very important is different to direct post, there's very little cement space. So the reason it lasts for longer is for all the cements, the bonding or the cement will degrade over time, especially the larger the cement, whereas the cast post and core does not rely on the cement space, and hence the best longevity. The biggest disadvantage is of course, everyone's, they're so rigid, and then especially using when there's no ferrule, where is the force going to go? So the one complication happens is going to be vertical roof fracture. To ensure you minimize the risk, occlusion needs to be controlled very well with a shim stock clearance, and any bruxers needs to be have an occlusal splint. It's also increased time of 2 visits. There's a need for temporalization, which Dr. Bentley will cover at the later stage, and then the cost of the semi-precious or the high precious post. The biggest concern will be, there's a transportation or distortion of the impression during transportation, and then there's a more potential error because the technician needs to do a pattern or impression of the die stone to make a pattern of some sort, then to cast your post and core. And ultimately, retrievability is challenging as well. The crown needs to be removed should you decide to redo the root canal retreatment or apicectomy. When we look at the fracture resistance, this is an in vitro study. Look at the fracture resistance without ferrule. The cast metal have the highest resistance. They also did the second one where canal configuration is not very good, so they put multiple fiber posts in. So they put a main fiber post, and then they have accessory fiber post to support or to feel the canals a little bit better, and that does better than the CAD-CAM anatomical post. When there's no ferrule, they try to do this as like an amalgam core, but instead they do like a direct composite core without any fiber reinforcement. That one have the lowest fracture resistance. When we look at how they fracture as well, the cast posting core, as outlined in the literature, will fail by the vertical roof fracture. With the multiple fiber post, it fails by horizontal roof fracture. So it's been reported in the literature as well. Even with a single fiber posting core, will still have a roof fracture, but they fracture horizontally. When they fracture horizontally, it depends on where they fracture. Sometimes the tooth still have to be extracted. On the picture, if you don't have any post, it will just decoronate very easily. So when there's no ferrule, you still need to put a post of some sort to retain the crown better. Ideally, when there's no ferrule, cast post and core. But I always let the patient know that the tooth is compromised. And then now we have Dr. Bentley who will show us some clinical cases.
So Johnson, just to sum up, when would you recommend the use of cast post and core?
Yeah. So basically, when there is insufficient ferrule, and also when the canal configuration is not favorable, or basically I put in a prefabricated post and it's almost like floating. Yeah, just not stable. Yeah.
And in the case of insufficient ferrule and you decided to use a cast post and core, what would you be telling the patient? Because as you correctly said, that when things fail pretty catastrophically. So are we restoring these teeth for doomed for failure?
I do let the patient know these teeth are compromised. They definitely don't have depending on how much ferrule.
Not much.
It's like if there's
right?
not much at all, right? I can give them, worst case scenario could be 2, could be 5 years, right?
Right.
Yeah. But of course, I tell them, realistic expectation is, do not chew on these teeth. But this is on the provision we still have quite a number of functional postural teeth remaining. But if we only have only the anterior teeth remaining, and I'm doing a cast porcelain core, then the prognosis of these teeth is not very good, even though it's a cast porcelain core.
Yeah. No, absolutely. I do have an interesting case that I'll leave the best for last.
Yeah.
For all of us, or challenge, or all of our sanity. Yeah. So I'll quickly. I know the evening it's getting long, and I'll quickly just go through a clinical case of cast porcelain core as well as provisionalization, because many clinicians, I think, when we're going through our undergrad degree, we always have to do a couple of cases, and sometimes you get really traumatized by that experience, like having some sort of problems along the way. So I do know many clinicians try to avoid doing cast porcelain cores like the Black Plague because of that bad experience that they've had. So a little bit of tips and tricks. So this is a case where the pre-existing some form of direct post and core that's dislodged, but the patient really wanting to save the tooth. So we could see that from the occlusal aspect that we have a reasonable amount of ferrule. Not ideal. Also, we do have a circular canal that's reasonable, that's with a small taper. So I thought at the time that perhaps a cast porcelain core was a good idea, because that we're really challenging on the amount of ferrule that we had. I've also prepared on the palatal aspect with a small little groove just to give that anti-rotational feature that Zoe mentioned early on. Now, there's 2 methods to help you to construct your cast porcelain core. The first method is using some sort of a pattern, typically some sort of resin. This one is a GC resin pattern, which I think we like I said, sometimes it really traumatize us back in undergrad, because sometimes these things can get stuck inside the canals because you haven't lubricated well, and other times it's really sort of deformed and just didn't look good. But otherwise, in experienced hands, I do find this is quite a good technique, because you get to shape things, it's particularly the core, exactly how you like it, and then you send that to your lab to get it casted. That's one option. Another option, of course, is taking an impression. And one of the question from the audience is, well, how do we take a good PVS impression? So once you finish preparing that post space, and again, following Zoe's principles that she's covered, my personal favorite is using the lenticular spiral to, on reverse mode, in a slow RPM, right, spinning that light body PVS down, because there are risks that that lenticular spiral binding into your canal space or into the into the gutta perca, and then end up separating that file, which is then that's absolutely catastrophic.
There should be no force. No force.
No. No, and especially at a slow RPM, that's usually I find it's quite safe. There's also the other idea of do you use some sort of reinforcement when you take that impression. There are some clinicians may use something like a plastic, like a burnout post of some sort, to try to strengthen it. Others may use something like a paper clip. That's a variety of different things people have shoved down canals with the aim to make that long, skinny, light body PVS, which is really bendable, flexible, making that more rigid. The rationale for that is when you don't, they have had the bad experience that when the cast porcelain core comes back from the lab, it fits the master cast, but it doesn't fit the mouth because there's been some sort of distortion. I think that's so while reinforcement is perfectly fine, whatever you want to stick down there most of the time, but do coat it with some PVS adhesive so at least it binds to it.
I find that often that space is so fine, From an accuracy and the material capture point of view, like no reinforcement is actually fine. The distortion doesn't actually come from the impression process. It's more in the post-impression, the handling, how that impression travels and how your lab handles that impression. It's more in that process of causing any bending, including as they construct the model, whether they makes the stone too thick or a bit more passive in that construction of the model. So I totally agree with you. If you are using a reinforcement, though, you really have to make sure it's coated with the adhesive, as well as that actually doesn't perforate the material itself, and it's often quite fine, because sometimes when you don't use that reinforcement correctly, that in itself can impact on your impression taking.
No, absolutely. And because I find the majority of the time the problem comes, like what Agnes is speaking about, is incorrect laboratory handling of your impression. Because who is the technician that usually pour up a master cast, right, at the lab? Is it your most senior guy or your most junior guy? Unfortunately, right, in most commercial labs, it's your most junior guy, right? So they're the ones often, unfortunately, have the least amount of experience, and they treat these PVS like any other PVS, which they mix up with dye stone and then just slap it on. And that dye stone ultimately would compress onto this really flexible material. So of course, that causes some degree of inaccuracy. So there are certain techniques that labs can employ to help you to reduce that. One, it could be that they could literally using a paintbrush and paint on a very, very thin layer of dye stone first. Let that set. Then when that sets, right, then you can lump on the rest of the dye stone. Or you can copper plate it if you're a purist at heart, which we've all done in pros, and we always love to see a bit of a copper inside. So there's a variety of different things that our labs can do to make the master cast as accurate as possible, even without any reinforcement of your impression. And then when they make that cast post and core, things will fit so much better. So a couple of things to talk about with your lab as well. And then, of course, whether you take an impression or whether you made a pattern of some sort, and then your lab can whip up a cast post and core. After cementation, typically then you will carry out your final crown preparation. Once again, this is one of those long bevel ones that I'm really going sub-gingival and obtaining a good amount of ferrule, not just relying on the cast post itself, and then achieving a reasonable aesthetic outcome. Provisionalization is another thing that haunts a lot of people, because there's very little tooth structure usually you have. That's why you decide to use the cast post and core. So how do you provisionalize these cases? You got two options. One is some sort of a fixed provisional. Here you can see I'm done a little reline of using some sort of a post able to maximize the retention and resistance of that provisional crown. But even having said that, there's a very high risk for that temporary bond or temporary cement to become flexed and then result in some sort of marginal leakage. So that's not my favorite technique. And the other method is a removable provisional. So for example, take this case here, for example, we got 4 anterior teeth. They're all heavily restored with composite, and a pre-op PA that I've taken. I know there's very, very little tooth structure underneath. So I'm really prepared for it. So first I quickly just change the shape of the composite just to make it look a little bit nicer. And then I've taken an alginate and then extraordinarily made a pull down. So this is all done before managing the case on the day. Then on the day of treatment, you can then deconstruct, pull everything apart, assess whether these teeth are still restorable. In this particular case, it's a very young lady. She really wanted to save her teeth at all costs. I think she was in her late teens. And then, again, due to the significant amount of tooth loss and also a very tapered and actually quite large canal, because she had root canal treatment done when she was in quite a young age. So therefore I've decided to use cast post and core in this case. Taken the impression. Now in terms of provisional, a little bit of a cotton pallet deep down, and then plug it up with either RIM or Cabot. Now, research has shown that you need at least 5 millimeters, vertically speaking, of provisional material in able to reach a fairly good endodontic seal. Anything less than 5 millimeters, these research have found is bacteria penetrating into the root canal. Then of course that's not good. Our endodontist is not going to be very happy with us. Now, to make the provisional, here is actually the easy part. You simply just inject your bisacral, your ProTemp, your Luxatemp, one of those things, injecting it into the right shade, and then squish over the top of those abutments, which I actually also apply some Vaseline, and then you can actually remove this and do a little bit of trimming to get rid of any any potential undercuts and bits and pieces. So that's, in other words, the provisional bit is actually the quick bit, and this makes a removable provisional. You do have to communicate with your lab, of course, try to get these cast, post, and cores made fairly quickly. And then once they're cemented, we put the provisional crowns on. Now, in this case, being an anterior, I've also coated the cast, post, and cores with some opaque to help to block out that, otherwise that gray color that's showing through the teeth. We don't have enough Ferrule here, so then I've transferred her to my periodontal colleagues who done some crown lengthening for us, and I think we waited at least 4, if not 5 months for the soft tissue to mature, and then did the preparations, made 4 PFM crowns, and then again, finishing the case, reaching a reasonable outcome. So that's that. Now, just before we go to final remarks, now there is a very, I think, interesting clinical scenario I think perhaps could tie everything that we've spoke about together. So this particular question goes something like this. The patient has a fairly deep bite. Mm-hmm. It is an upper central incisor tooth. The patient unfortunately has broken the crown and the core, as well as a little bit of ferrule, so there's not much ferrule left. What would be your recommendation here in terms of if we're going to restore the tooth, what sort of post system will we use, and or even just to be used as a long-term, perhaps provisional, until, I'm assuming, the inevitable, which could be an extraction or an implant or something else. So there's a occlusal problem, there's a ferrule problem, there's an aesthetic area, and needless to say, it's a very challenging situation.
Indeed.
Any thoughts on that?
Well, if there's no ferrule, it's important to explain to the patient that this tooth is compromised. So definitely lower their expectation to making it like as a short-term solution until a more definitive treatment option can be established. But in these cases, it all comes back to probably finances as well. If we look at the cost of doing, whether we do a post-cast core crown versus, and perhaps maybe ortho extrusion or crown lengthening on this tooth versus an extraction and an implant, maybe there might be, and the long-term longevity of the tooth, maybe there might be a benefit to saying, look, this tooth might not last you another 3-4 years. Do you want to spend an X amount of money on keeping it versus taking it out and just having an implant? But if there's a medical or the patient conditions or the patient adamant to keep the tooth, then definitely being a central incisor, central incisor, then we could do some of the nice cases that you've shown with the subgingival, like a margin preparation. Knowing it's a short term, I might even consider either a fibre post for depending on what sort of restoration at the end, or a cast post course, just depending on where we want to end up with. Is it a provisional crown that's going to go on top of it, or is it all ceramic or a PFM crown? So that's all going to dictate which kind of post we use.
Yes. Yeah. Johnson?
I think we are pretty conservative practice, regardless of the post system. We're always trying to achieve a ferrule.
Yeah.
Sure. So regardless of the post system, but usually our patients understand that they are compromised. So depending on how compromised they are, I mean, in this case, the deep bite, insufficient ferrule, That's pretty high risk. Perhaps with ortho extrusion, but then with a deep bite, there's not much tooth to work on.
No.
So for me, the best case scenario for this tooth is to last for a year or two with all, everything we throw at it.
Right.
And it's going to be expected. Loading is quite high as well. Yeah.
And in terms of your post and core, to answer the question, what would be your post and core of choice?
Post and core, cast post and core in this case, should the patient, favor to treat
Save
this
the
tooth.
Yeah.
And then is there any occlusion can be changed to reduce the bite? Intrusion of the opposing teeth?
Yes. Yeah. Agnes?
Enamoplasty.
That's right.
Yeah. So it's like you ask 4 different prosthodontists and we get 4 answers.
Yeah.
4 different
But I think
as always.
I think in the nutshell though, it is a very legit scenario that we do face. What the consideration that hasn't been spelled out here is probably, but Zoe has mentioned, finance of course is one thing. Patient expectation of how long this temporary long-term thing is actually they have in mind, but also the age of the patient. I think the age of the patient also says a lot in terms of when is the next rehabilitation plan, and within what they can consider what that final outcome may be. So really, it's just 2 scenario really, given that what we've been asked is ultimately we've already decided that we're keeping this tooth fixed restoration.
That's the
not
assumption.
really that's the assumption basically presented to us, but the tooth is highly compromised. So in my humble opinion of talking to the patient is that if the patient is not going to immediately consider root canal retreatment, and again, assuming that you're throwing at us, there's no signs of immediate need for endodontic retreatment as well, and that they are quite financially limited, they probably just need a length of time to prepare for a bit more ultimate destination of what they deem as a predictable and definitive management. Then in that scenario, I may try to attempt a direct resin fiber post, improve the ferrule as much as possible. I would still let you know, usually in that kind of circumstance, I would assume previously already been having a crown. If there's enamel, great. That would be further adding to my lack of ferrule kind of balance to resist that flexion. But where possible, if I can actually improve on the ferrule, and to save costs, it can even be some kind of a resin or a glass crown delivered by the laboratory. So it still somewhat have a balance between bonded and a ferrule fit, and just pray and last for as long as possible until that next phase of whatever the patient deem serves right. And as Johnson also say, is patient information to really minimize any flexion of that tooth. Wherever possible, we can change the occlusion or whether make the palatal aspect thinner. So despite the deep bite, it is being helpfully guided by the neighboring sound dentition, not neighboring weak dentition, etc., etc. But if the patient actually is of an age group or an affordability and understanding of the particular risks that may be involved, and they can actually elect to perhaps consider root canal retreatment, so as sound as can be inspected the internal tooth structure. To conserve any further tooth preparation, I would go with what Johnson said, cast post core, ferrule as much as possible, and still have all the other mindsets involved to minimize the lateral loading of the tooth. But yeah, it will yield still a not a great prognosis, but all the aspects have been done in situ to give the tooth the best outcome versus extraction or replacement, etc. So I think patients' age, decision making, involving them in the decision making would probably be ideal.
Exactly what she said. That's why I leave you to recap for us, Agnes. I'm also quite glad that no one said an implant post as my favorite post for that particular scenario.
Oh, but implant posts can break too. Implant posts can fracture too.
Absolutely. We've seen patients break everything, haven't we? So thank you so much for listening, ladies and gentlemen. What I'll finish off with just a quick, perhaps one sentence summary from each of the presenter. As always, just to wrap up the evening, I'll kick us off from Zoe. What would be your final remark for the evening?
Okay, it's always hard in teeth. Not so sure, like 50-50, is it enough tooth structure? Maybe do we need a post or no post? It's hard to visualize the tooth prior to crown preparation. So on that, perhaps preparing like a conservative crown prep and then assessing, okay, what's remaining of that tooth? Is it less than 1 millimeter? Does it give us the sufficient 2 millimeter thickness to resist any functional load? That will help us decide definitely, okay, this tooth doesn't have enough. I'm going to supplement it with a post to help retain.
Terrific.
Cool.
Johnson?
Yep. For me, it's about letting the patient know the realistic patient expectation. I mean, I always tell them, if you give me good tooth, I can make it last 10 plus years. If you give me a compromised tooth, I can make it last up to 7 years or less. And everyone be realistic, and then we will prepare for the inevitable.
Yeah.
What that will set their mind is they'll be very careful. They know it's a compromised tooth.
Yes.
But also when the inevitable comes, then they are prepared for either retreatment, recrowning, or potentially replacement.
Very wise, as always. Agnes?
I think my take-home summary is remember that the need of a post is, again, really just if you needed to retain your intracoronal restoration with relevance to what you actually choose as your final restoration. And while I think a lot of us would know that, any rigid post system tends to fail with tooth fracture, and resin bonded fiber post is a bit more forgiving if it tends to fail with debonding and a chance to retreat. It's still important to actually consider whether you do adhesive dentistry or not, is having that Ferrule or that actual, what is the retention mechanism of your final restoration that sits on top of your post-core choice, because if it is not considered rightly, it would either be failing through that fracture mode or the marginal seal having challenged.
Absolutely. Personally, I think since we are talking about post space and all that, I think if possible, when you're trying to prepare your post space, if you can prepare the post space without removing any dentine, fantastic. Then you're not putting too much risk into the root canal system. And if you do have to remove dentine, obviously the lesser, the better. And ultimately, try to rely on your Ferrule effect as opposed to the post itself. Only therefore, for some reason, there's absolutely no way to obtain any Ferrule, then perhaps a cast system or a rigid system may perform slightly better than a non-rigid system. So once again, I want to thank the entire panel for their hard work behind the scenes, Brett for making us look good on camera, and of course, last but not the least, you guys for listening, for all the wonderful questions, and also for your eternal support and trust in us to look after your patients. So until next time, thank you again once for tuning in. Take care, and have a wonderful evening.